All right, Doc. We are back, and it's the last show of the year. Can you believe it? The last show of the year,
Yeah, we're at the end of the year.
2019.
It's going to be the last one for sure.
Yeah. So we got some good questions again from all over the world. Thank you so much, you guys, for sending all that stuff. We appreciate it, and the questions are getting better
Very
and
much.
better, Doc. Right?
They are. Yeah, they're getting more intricate and more thoughtful and a lot less general, we'll say, for sure.
Yeah, that's awesome. So you want to start with number one?
Sure.
Hi.
Number one, hey, Doc. I would like my name to stay anonymous because I am very ashamed of my stupid decisions. I'm 16 going on 17, and about 3 years ago, I used a pro hormone thinking it was a regular supplement because it was so easy to get. I also used Ostarine, the numerical designation for Ostarine, MK2866, about a year after the pro hormone and noticed some sides, but very mild. It's been over 2 years without PED use, and I don't plan on using any for a very, very long time. For about a year now, I've noticed low T symptoms such as fatigue, low blood flow down there, fat gain, and overall less manliness. For the past 2 months, we all know what he means, right? For the past 2 months until now, I have also noticed the worst gyno I've ever gotten. The lumps are getting noticeable if I don't wear a tank top underneath the shirt, and the nipples are sensitive, especially the left nipple. I told my doctor, but he thinks it's a normal pubertal hormone imbalance, but he doesn't know about the PED use. I'm currently 185 pounds, 6 feet, and about 17 to 20% body fat. Let me know your take on this and what I should do. Thanks. Well, as always, I appreciate the questions, and I have to state, like we do at the beginning and at the end, I think, I can't give you medical advice, but I can give you some observations and some information, and hopefully you can do something with it. First of all, it probably wasn't the best idea. I definitely don't mean to be rubbing it in, but I think to get the point across to not only you but everyone else, when you're still developing your what we call your hypothalamic pituitary adrenal axis, it's not a good idea to mess with it by throwing in some exogenous substances that are being produced by that axis, because the body will develop that axis differently, we come to find, in many, if not most. Everyone's different. It depends on how much hormone you use, and I think more importantly, for how long you use those hormones or prohormones that affects the development of that HPA axis. So it may be something that is going to be an issue for the long term. Again, you're still pretty young, so it may work its way out because you're pre-programmed to continue developing till roughly 26. The number changes every year depending upon the science. But with that in mind, the year 26, in other words, I typically don't recommend anyone try, experiment, or be prescribed hormone therapy except in some really rare circumstances, because we want to give the body a chance to do what it can on its own. So what do we want to do? I would stick with a good doctor to help guide you through this. What we want to do is coax whatever's not working to work again, whether it's the pituitary gland or the testicles themselves that aren't working. Very likely it's the pituitary gland that's at the heart of all this, because again, very, very young, the testicles don't go to failure until much later. That's what we call primary hypogonadism. But at this age, it's probably an issue with they're just not they're not receiving a signal, the testicles, from the pituitary. So, excuse me. One thing we could do is, one option your doctor might recommend is using HCG to make sure the testicles are working well again, because I like to call them the diesel engines. It's much easier to keep them running, and if they've stopped, harder to get them started again typically. If we can get them started again by forcing that upon them using an analog of luteinizing hormone, HCG, then we can pull that away either abruptly or slowly and see if the gas engines, the pituitary gland, doesn't kick in right away and everything gets running the way it's supposed to much more easily than if we just go cold turkey and wait for the pituitary to continually send signals to the testicles and they finally, get the sleepy out of their eyes and get cranked up again. I don't mean to oversimplify it, but it's a relatively easy way to see what's going on. One of the things we have to always rule out in this case is a pituitary microadenoma, which is a fancy way of saying there's a very small tumor, and it's typically not a cancerous tumor, on the pituitary gland that's blocking the pituitary's function. You say, well, no, this has got to be what it is. Well, maybe, maybe not. Maybe it's just correlated, and it happened to be through circumstance occurring at the same time. The effect, and the effect is blamed on anabolic steroid use, or in this case, a SARM. And while we're at it, I think we've talked about this before. Ostarine is not my favorite SARM. I don't like SARMs in general because, briefly, you can get so much more out of what we already have in the medicine chest, so to speak, than these SARMs, both in terms of effect, lack of side effect, and even cost. So, and I think I've talked about this before. I understand why people like to use SARMs, the freedom of it, not having to be told
it's
by a
cheap.
doctor.
That's for sure.
Yeah, I don't think they're cheap anymore either, if they ever were. But yeah, I wouldn't go back and revisit the Ostarine ever again either. As far as some of the other things that might be going on, in the meantime, while you're waiting for the HPA axis to continue to develop and come back online, or while you're coaxing it to do so with different methods, and again, at that point, maybe consider seeing a doctor who can give you more options than I'm presenting here. A lot of docs like to recommend just using clomid, clomiphene citrate, to get things going again. It's, again, a good option too, a little less forceful than to tell the testicles to work with HCG. But in the meantime, if you're having erectile dysfunction, for example, PD5 inhibitors like Viagra, Levitra, Cialis are great choices. Cialis, I would say, until recently was the best choice because of the onset side effects being much less than with Viagra and Levitra. The stuffy nose, the red eyes, the potential for a headache, and seeing blue like with the Viagra, which they freely admit can happen. And they happen because they're not strictly PD5 inhibitors. They're PD8, PD9 inhibitors. Excuse me, not pure PD5 inhibitors. And the closest one we have to that, again, until recently, was Cialis. But now we have Avanafil. The problem with Avanafil is it's quite pricey. It's the new boy on the block, and it's a lot more expensive than some of the others that have been around for a while and we can get generics of. But again, in terms of no side effects, just FYI, Avanafil is a good one. In terms of the fat gain and fatigue, well, testosterone is important to prevent those two things, but there are other causes of that too. Didn't mention anything about laboratory assays here. So let's confirm that that's exactly what's going on versus maybe this is something else and we're blaming it on the PED use when we may have something else going on here. So again, that's why I don't want to play doctor on a case-by-case basis like this over the over the airwaves here, because it can be a number of different things. So you should see a doctor. But if we make some of these assumptions, then maybe you're going to have to watch what you're eating even better, concentrate on getting more rest and recuperation, because you don't have the benefit of the leverage of testosterone in those areas, right? So just got to be smart. Hopefully I'm contributing a little bit to that anyway. And at this point, I don't know if there's anything else I could say that's general enough to not get into giving you, specific advice. Definitely look into gynecomastia. You want to make sure that your estrogen levels aren't going too high. Well, he says he's got the worst gyno ever. Sorry, I thought it was wasn't any more than just nipple sensitivity. But that can very often happen, and you want to jump on that right away, because then you're talking about typically a surgical corrective measure to get rid of those lumps, if you will, that occur and aren't pleasant, both in terms of cosmetics and also pain. They can hurt.
What's the what's the earliest patient you ever had yourself as far as HRT? Because you said that very rarely happened when they're in their 20s, but I'm sure it does happen sometime. You personally, what's the
well, there's some issues we find out through karyotyping, where someone might have something called Klinefelter's syndrome, where you have an extra X chromosome. There are some other dysfunctions that can occur with the cascade of hormones and the enzymatic processing from one hormone to another that occur where the androgens don't, I don't want to say fully develop, but they don't bring their way down to testosterone like they're supposed to. I'm trying to keep it as non-technical as possible. But there's some certain genetic predispositions that once you find out that's what's going on, we realize, hey, you're not going to get rid of an extra X chromosome. We're not going to get rid of, and by the way, that's associated with low testosterone throughout life. And some of these others where there's no fixing it right now, there's only, putting a Band-Aid on it, we call it, treating the symptoms. So to answer your question, I mean, honestly, these things, puberty starts variably in men and women. So, maybe 13 years old, I mean, what do you know any different from being 12, 13, nothing changes. Then you start looking around you, maybe by the time you're 16, you realize, hey, you're not developing like someone else. And then you go through a battery of tests. Now it's quicker than it used to be, but you might go 2 years, from that before you find anything. So 18, and then there's a lot of talk about what you're going to do about it. So again, trying to answer your question, I don't think I've ever really faced anything like this. Finasteride syndrome is another thing that people talk about, whether it's truly because of finasteride or not. And I had an interesting case with this recently that really kind of applies here. You don't want to use something that messes with your hormones in that regard either. Is there something that occurs after age 26 called finasteride syndrome? I think it still remains to be seen. I don't have evidence of it. And I think we talked about this in prior videos. But you can certainly make a case that before that HPA axis is formed, we could be messing with the formation of that axis, right? The same way I'm talking about, where if someone uses finasteride with or without a prescription, or anything else that messes with those hormones, you could disrupt their the development of that axis, right? So, where was I going with this? Sorry, I'm going off on tangents. I was going to say that I had a guy come in who was 20, and he used something that disrupted his hormones. I gotta be careful here what I say because I don't want to get sued for naming particular drugs. But I think my point's taken that in those cases it's early, but for the most part, most of what I see occurs somewhere around age 35, where kind of by definition paraandropause, perimenopause occur. And stress can make that age a little bit earlier, but it's rare that you see somebody at 20, 21 years old. There's also the pituitary microadenomas, which you talked about earlier, which those are growths, and those can happen early on. But normally you don't, at that age you don't treat with replacement therapy. You might temporarily use some sort of treatment until they get the surgery to remove the lesion. But
they have to do surgery.
Yeah, it's restored at that point.
Cool. All right. Thanks, Doc.